Thank you, Jordan, for that kind introduction, and good evening and to you all. It's a true honor to be here, back in Toronto. As Jordan said, I was born and raised here in Toronto, up in North York, and it's a very emotional trip for me. I've been back a few times. It's the first time I'm back during the winter. And, and I have to say that it really reminds me of coming, for the Maple Leaf games or the Jays games to this area of town with my dad. So very emotional. Thank you. It's a true honor to be here. And I couldn't think of a better opportunity to be here because I truly believe that if there is a country that should be eliminating hepatitis C very quickly, it's Canada. You have everything to do it. And so following Jordan's call and Jason's, I feel that I'm honored to be now part of this calling to get the ball rolling and to join forces with all of you. But despite my Canadian connections, this is where I live now. I really can't complain, to be honest. And it looks like this right now. I was elected into Parliament after 7-8 years working as a physician in infectious diseases, and this is my office now. It's a 16th century palace in Lisbon, and so this is where we work every day, and we have 230 members of Parliament. I have to say that I was inspired to become a politician during a school trip to the provincial parliament here in Ontario, in Toronto. And I remember when I was a kid going there with the school, and they were saying that the best students would be invited to be water boys for the parliamentarians. And I thought, wow, I really want to do that. And I started working really hard. Well, now that's where I'm sitting. But anyway, we're 230 members of Parliament, only 5 doctors and 5 healthcare professionals, and I'm the only one with an ID background. So you can imagine that sometimes discussing more technical issues can be a challenge, especially when you're in a health committee surrounded mostly by lawyers. It's never a good thing to be surrounded by lawyers, but in this case particularly. And in Portugal, back in 2014, we were having this hearing with the Minister of Health. And this guy who was in the room. So just to give you some background in this picture, during the year before that, in my position as head of public health at the university, I had started working with all the stakeholders, politicians, health managers, physicians, patients, working on a consensus of what Portugal needed to do to prepare itself for the paradigm shift that was coming with DAAs. In Parliament, it was very difficult to discuss this issue. People were really not aware of it. We're back in 2013, 2014. So we started to use the university to build up the evidence so that we could push for the cause using that evidence in Parliament. Sadly, things weren't moving very quickly until this day, until the day that we had this hearing with the Minister of Health and this guy who was infected with hepatitis C and was waiting for treatment and had written a letter to the Minister of Health saying, listen, I have enough money to pay for half of the treatment, but I need you to pay the other half. And he didn't get a response. So he went to this hearing, and all of a sudden he got fed up. He stood up and he started screaming, please don't let me die. Coincidence or not, 2 days later, in February 2015, the Minister of Health held a press conference. And not only did he announce full access, universal access to treatment to all patients, unconditional in terms of clinical background, but he implemented most of our recommendations. He implemented a risk-sharing model in which we wouldn't pay per pill or per cycle of treatment, we'd pay per cure. And we would pay based on a centralized system. So instead of having each hospital negotiate, we'd negotiate centrally, making sure that there weren't any regional disparities, making sure that if you were in the north, center, or south of Portugal, everyone would have access to the same kind of treatment. It was a volume-based agreement, very important to make sure that the Minister of Finance was on board, because until then, basically, the more patients you treat, the Minister of Finance would just call the Minister of Health saying, please don't treat any more patients. It's getting too expensive. Now, with this volume-based agreement, the Minister of Finance started saying, why aren't you treating more? We need to lower that price. And then a national action plan was called for, still not there yet. Well, I hope we will get there. And tomorrow I'll be able to talk to you more in detail about what we're doing. And the national HCV treatment guidelines have been constantly updated ever since, and that registry was created. And this registry is basically used not only to follow the patients, but also so that payment can be performed based on cure status. So today, over 17,000 out of the around 60 to 80,000 estimated patients have been diagnosed. Of those, 12,380 have already initiated treatment. Over 6,000 have been clinically cured with a 96.5 SVR rate. So these are lives that have been saved. And looking at what this actually means, over 3,400 premature liver-related deaths were averted. We gained over 62,000 life years. We avoided more than 300 liver transplants, almost 2,000 liver cancers, and more than 5,400 cases of cirrhosis. And because money talks, more than 271 million euros on treatment costs related to Hep C complications were avoided. So these were true savings. So that's a summary of what I'm going to be talking about tomorrow, the Portuguese case. But I want to talk now a little bit more of where health systems have to go to and how Hep C fits into that, and then the role of the different decision makers and players within the system. I believe in the European model. I have to say that I'm biased. In Portugal, I'm known as a social democrat. In the US, I'd probably be named a communist or something. But I believe in universal access to care. I believe in equity and access. Believe in high quality healthcare and solidarity and funding. But when we look at health systems around the world, Portugal, Canada, any OECD country, we see that we have one of two options. And this study from 2013 shows that very clearly. We can either be on the bottom or at the top. The bottom is saying that costs in healthcare will rise, but will rise in a way that we can finance it in a sustainable manner. Or we'll be at the top, which is the situation in which we do no reforms. We just keep doing business as usual, and the costs will keep going up to a point where it will become unsustainable. So either you do what needs to be done today and make sure that you continue to have a universal health system, or you don't. So if we acknowledge that we need to perform these reforms, then we need to understand what we need to do. And for that, we need to take a step back, and we need to understand the principles of medicine. What are the goals of medicine? Looking back at the Greeks, the Egyptians, the Romans, and it was very simple back then. We needed to promote health, preserve health, restore health when compromised, and minimize suffering and malaise. However, in the 19th century, we had the Industrial Revolution. Phenomenal achievement of society, which has led to many advancements that we benefit today. And it has influenced the way we live and the way we do things. And you can see at the bottom part of this slide that the way we make cars is still very similar. The problem here is that back in the 70s and 80s, a lot of business schools started looking at car plants and understanding how efficient they were, looking at these Japanese car makers and saying, wow, this management model really works. Then they started looking at healthcare and hospitals, at the time mostly run by doctors, and saying, these guys really don't know anything about management. Why don't we pick up on these Japanese models, transform it into something that we can use at the hospital level and make healthcare function more efficiently, and making sure that they start using these rules. And that led to what I call the industrialization of healthcare, in which we started to focus more and more on efficiency, meaning efficiency that we can produce more and more quickly, more surgeries, more hospital visits, more emergency visits, more treatments, more care, with the belief that became a dogma that the more efficient you are producing, the more efficient you are on the industrial production line, more healthier the people will get. Well, the truth is, not only have costs risen all over the world, this is just one example, but waste has risen. And most importantly, we have failed to reduce the burden of disease. And this is something that is seen all over the world. It's not just in the US. You have many examples here of some of the richest countries in the world where costs are all on the rise and uncontrolled. And in all of them, there is a rise of the burden of disease. And this is something that everyone acknowledges. Even within the World Health Organization, they're saying, listen, health systems are becoming unsustainable. So what you need to do is very simple. Just follow the pyramid and we'll make health systems sustainable. And what they say is start at the top, get rid of anything you're doing that is not truly adding value, and make sure that you focus at the bottom. You have to focus on health promotion and prevention, and you need to focus on structural reform. However, in most OECD countries, we're spending 3% or less on health promotion, on prevention, which means that we do not have health systems. We basically have disease systems that spend 97% of our budgets reacting to disease which is on the rise. And it has become a vicious cycle that will lead to unsustainability. That's why Michael Porter down at Harvard said that in healthcare, days of business as usual are over due to chronic diseases, raising costs with innovation and technology, need for more qualified health workers, demographic pressure, social inequities, raise of burden of disease. As I talk to many politicians, I normally use cartoons. It helps me get the message through. And so bear with me, and I'll try to explain Michael Porter's vision using a carrot. Think of the carrot as an incentive, be it financial or something else. And this is the modern hospital of most OECD countries, the Western world. And it's a factory where we're basically telling managers, listen, the more surgeries you do, the more money you get. The more patients that walk through your ER, the more money you get. And it's funny that if you listen to ministers of health in any OECD country, at the end of the year, they're always very proud saying, this year we've had more hospital visits, we've had more people going to our ERs, and we performed more surgeries. And nobody stops to ask, isn't that because people are just getting sicker? And that's the problem. And so Michael Porter said, what if we just picked up on that carrot and put it where the patient is? Instead of paying hospitals based on the number of surgeries and the number of any other care performance indicators, why don't we just pay them based on health outcomes? If people get healthier, they get the money. If not, they don't. And here's a very good example of that. This is from ISHOM, the International Consortium for Health Outcomes Measurements. It's using the prostate cancer example. So this is the results of prostate cancer surgery in Germany, Sweden, and at a university clinic in Hamburg, the Martini Clinic. And if you look at overall 5-year survival, you'll see that they're all at 94, 95%, pretty similar. And that's what most healthcare systems measure. However, if you look at the right side of this slide, you'll see that 1 year after the surgery, urinary incontinence is present in 43% of the German patients, 50% of the Swedes, and only 6.5% of those operated at the Martini Clinic. If we look at erectile dysfunction, 1 year after the surgery, 75% in Germany, 80% in Sweden, 34% at the Martini Clinic. So if let's just pretend we all had prostates in this room, where would you all prefer to be operated if you needed? At the Martini Clinic, right? Because living is more than just surviving. It's quality of life. And if you look at this, you understand that the Martini Clinic did something to focus on what matters to patients. And they did this extraordinary thing, which was talking to patients. And they asked them, what is important to you? And they performed these queries 1 year after the surgery. And then they built a financial model in which they had a payback system to their healthcare professionals based on the results. So the surgeons started looking for better surgical interventions that could actually perform better, not just on overall survival, but on other health outcomes that are important for the patient. you can understand, looking at this, how it is important to create the right incentives. And if you're thinking about HCV, and we understand that one of our challenges is actually to find the patients, possibly we need to create those financial incentives within communities to go after and diagnose all of those undiagnosed patients if elimination is a true reality, because access to treatment alone won't achieve elimination. So if we look at money into a system, we understand that it's not the whole story. You can see on the left side of this slide, so this is basically health expenditure versus health outcomes. And when health systems are in a less developed country, you see that the more money you put into the health system, the better the health outcomes, until you reach a certain point. Let's say Singapore, one of the best health systems in the world. Then you can see that it kind of plateaus. Putting more money into the system really doesn't result in better health outcomes. And then when you reach the US, it actually declines a little bit. So that means that pouring money without structural reform into a system is not enough. What this value-based approach that Michael Porter developed will do is will make our lives a little bit better. It'll probably push the curve a little bit higher. So with the same amount of money, we'll probably have better outcomes. But the big question is, how do we get to this third line? How do we keep outcomes going up, and up without spending beyond our resources, beyond our capacity, making sure that it's sustainable? Well, we have to acknowledge that most of the time when we have a patient in front of us, we are basically dealing with only 10% of what really matters in terms of defining their health status. 30% depends on genomic factors. There's technology now coming up that we can help modify it, but we're still a step back. And then 60% depends on exogenous factors, social economic factors, behavioral factors. And acknowledging this is extremely important, because only understanding this will we fully understand that we need to have take a step back and understand that our interventions need to go beyond the hospital. And so we have to understand the importance of these social economic determinants, such as understanding that poverty is the main conditioner in terms of health status, understanding that unemployment or bad work conditions can lead to worse health, or lack of housing, or lack of water and sanitation and whatnot. So using this argument, I would say that Michael Porter's vision is limited, in the sense that he's only looking within an insurance system or into a private health system. He's only looking within the hospital. And the problem with that is that hospital managers then, having this kind of model where the carrot is where the patient is, he's only looking at the patients within his own network. He's not worried about who's outside of that network, and he will probably select patients artificially, trying to get those patients that will get quick and better outcomes sooner. So what I suggest is that we pick that carrot and we put it in the middle of the community, so that we can focus on those different determinants, and that we can create financial incentives that will lead managers to not look just within a clinic or a hospital, to look over a community, making sure that we create right incentives to lower incidence and prevalence of diseases, for example, such as HCV. And so that we can focus on what I call the CBOMs, the community-based outcomes measurements, in which we look at these measurements and we can use them to create financial incentives. And so that leads us to what is value. Value is outcome over costs. The better the outcome, the better the value. It's a very dangerous equation. Governments tend to look only at the cost side, because if cost goes significantly down, value will go up, but that will not necessarily translate into better health. And all of us have a responsibility in defining that value. As you can see here, regulatory agencies, management, everyone when it comes to quality, and then resources depends on parliaments and governments. So instead of focusing exclusively on the role of payers, let's think more broadly in terms of decision makers. And I'm going to talk a bit about the role of a prime minister. My wife's a feminist. The prime minister here has to be a woman. And so and it's very important for all of you. Either you're a physician or advocate, or you work in academia or in the community, Everyone here has to play a role. If you really want to push for elimination, you need to play a role as advocates. And it's important when you speak with decision makers to understand how they think. So I've done a binary analysis, trying to translate how the decision maker thinks when you're talking to them throughout the conversation. Okay? So you're talking to this prime minister, and the prime minister is thinking, well, this is a very useful meeting, or this is a waste of time. Okay? Another thing that will come up to mind is, okay, I understand the problem. This person was very clear explaining it to me, or I have no idea what these people are saying. So you have to be clear of what you're saying. Another issue, this idea can really solve the baseline problem. So at this point, the person has explained the problem properly and has presented a good solution, or this idea will not solve the problem. Fantastic, I'll have something to show by the end of my term. The political life cycle is extremely important for a politician, or damn, I'll pay for it and the next person in the job will get all the praise. If you present it in that format, it might be harder to get the idea passed. Or this idea will resonate well with my base, another important issue for many politicians, or my base is going to kill me if I do this, even if it's a great idea. Lastly, wow, I can save money immediately. Naomi was talking about that. Or this is going to cost a fortune, which immediately pushes the person away. So now that you know how decision makers think, how will the health minister then push for HCV elimination? Well, you have to think beyond the health minister. You need to get the Minister of Finance, Social Services, the person giving out the money, and of course the Prime Minister or President of the country. So I know I'm off time now, but I'm going to ask for a couple more minutes so that we can all pretend that we're health ministers in the room. And we're going to do a very quick crash course in Health Promotion 101 for health ministers. It's a 4-step program. Very simple, very straightforward. First step, stop being a disease minister. Get a CEO, get someone to run the show on the operational level. And as a Minister of Health, focus on the political strategy side of things. It's extremely important. What most ministers of health end up doing is getting involved in the operations and lose focus on the strategy. And when the minister is not thinking of strategy, no one else is. Step 2, make sure that health and social services are under the same umbrella. You're looking at under the same budget. In many countries, since these tend to be on different budgets, they are not working in a coordinated fashion, which then leads to poor results at the end in terms of health. Get the Minister of Finance on board. Strike risk-sharing, value-based deals with them, as I showed with the Portuguese case on HCV, where we had that volume-based agreement so that the Minister of Finance could be motivated to see more and more patients on board. And step 4, make sure that the head of the cabinet is on board as a health promotion champion. Well, this is easier said than done. How do we do that? Well, getting political leaders to push for health promotion is extremely important. We have to present something that, of course, is in line with public concerns. We have to present clear before and after data. Many times we present very good evidence, but we tend to forget to present the important data in a way that is important for whoever we're talking to. If possible, present our idea showing savings, or possibly immediate savings, or at least no additional cost. And make sure that you present it in a way where you can present timely results. Of course, many of the results will only be 10 or 20 years from now, but you can break them down so you can show results in that 4-year cycle, so important to the politician. To help with this, at my university, we developed a tool called Let's End Hep C, which basically is an app that you can download or you can check the website. It's called letsendhepc.com, or at the App Store, Let's End Hep C, which allows you to do many things. We started with 6 countries as a pilot, trying to compare different policies. These policies, we came up with 24 policies with our expert panel, which are the policies that the countries need to develop to achieve elimination. And we've seen for each of those policies how each of the countries are, and we can compare those policies between the countries. But most importantly, it's a time machine that calculates the impact that these policies have in terms of HCV outcomes. And it calculates if the country is going to achieve elimination or not by 2030. And as you can see here, unfortunately, Portugal, despite universal access to treatment, will not achieve elimination by 2030. And we can see all of these different outcomes, and we can change the year. If I'm the Minister of Health, I want to see outcomes in 2020 when my term is over and not in 2030. Or if I'm the head of prisons, I can just look at inmates populations instead of looking at general population. Or if I just want to look at PWIDs, I can do so. And I can use the policy calculator. What we have done is basically we've gamified policymaking so that ministers of health at bed at night, playing around on the app, can actually change policies without anyone looking and calculate what happens. And they can see the year and the subpopulations in which it happens. And that is very useful because if our minister in Portugal would do that, he would quickly understand that the only thing he needs to do is actually put out an action plan that focuses at the whole of the cascade of treatment and make sure that he's putting enough resources into prevention and diagnosis and testing and linkage to care as he's doing on the treatment side, and he'd achieve elimination by 2028. So back in 2016, I coined this triad that I call EDD, which is what I believe we all need to do when we want to push for policy change. We need to be evidence-based. Most of the people in this room are very good at that. We have to be data-driven. Some of us are good at that, some of us not as much. We have to make sure that we present good data, not only today, but after a program or a policy is implemented, that we continue to collect that data. No policy is perfect, and we have to have data to perfect it as we go. But most importantly, we need to be decision-oriented in terms of policy making, which means that we have to design whatever we are proposing in a way that is sexy enough for the decision maker we're trying to convince to come on board and to do what we want to do. To help with that, last year, I founded an NGO called Unite. It's a global network of parliamentarians focusing on ending HIV/AIDS, viral hepatitis, and tuberculosis that was created with the support of UNAIDS. And we're working with parliamentarians around the world trying to push this agenda forward precisely with the idea that we need to get policymakers pushing for not only more resources into these fields, but also better policies to be done. So to end, I'd say that health systems around the world today and so mostly in the future will follow what is in this slide. We'll have that value equation where outcomes over costs will play an important role. But most importantly, that equation will fit in the idea of creating better health outcomes, focusing on what is important to patients, to providers, to healthcare professionals and health systems, looking at three main pillars: sustainability, innovation, and most importantly, social economic impact. So if we do that, hopefully we'll be improving health, we'll be improving care, lowering costs, and improving health in a virtuous cycle so that we can have better health for all. Thank you very much.
Thank you. Will you take some questions? Sure. Thank you, Ricardo. It was really a stimulating and interesting talk. And I do hope you get to meet some of our ministers while you're here, despite all the snow. I'm sure that stimulated some questions from the audience. We'll take a few questions now.
Thank you. That was a very, very interesting and enjoyable talk. One of the most interesting ones I've heard at a viral hep meeting in many years, and certainly gives us all pause to ponder a bit. While you were talking about inefficiencies with rising costs, I was sadly reminded, I've just seen data several months ago about the Alberta, which is where I live, and don't any Alberta docs sort of put a contract out on me, but I've seen bad data. Alberta physicians are the highest paid by fee code in our country. And all the objective indicators, we're paying docs more, but are we delivering better healthcare? All the objective indicators that, such as you've shown, show us the answer is no. So all that's happening is Alberta docs are just getting richer for doing sweet bugger all. So just a bad comment. I don't know what this way to go forward is. After all that rambling, I just want to ask a question. You know both political systems, Portugal and Canada. It sounds like Portugal's solution to the Hep C, at least you put in some kind of national pharmacare system, and your medical or political system, Portugal, sounds very centralized, whereas in Canada, of course, the provinces control healthcare. So how do you see the Portuguese model being adapted for our situation?
Well, thank you for that question, because I think it's a very important one. And when I look at the Portuguese system, Hep C was actually the first time we were able to do anything centralized. Until then, we basically had 5 regions. Of course, it's a much smaller country, but each region had some autonomy. And then in most cases, negotiations with pharma were done at the hospital level. And we have around 100 and something hospitals around the country. So you can imagine the disparities we would see within the country. The reason why we fought for a centralized program, making it exceptional, was because we had the firm belief, based on the evidence that we collected at the time, that elimination is only possible with this national effort. And so there was a huge negotiation with the multiple layers within the health system to make sure that they understood that this is what needed to be done. And it was announced as a national centralized program. So it was an exception. Looking at Canada, I don't want to, despite being Canadian, I feel on this topic of being a member of parliament in Portugal as a foreigner, I don't want to tell you what to do. But I would say that it would be useful for the provinces to discuss with the federal government what they want to do. Do we want to give universal access to treatment, which will end up happening one day or another, and pretend that we're eliminating? Or do we want to eliminate hepatitis C from the country? Which means that you have to have a vision in terms of the full cascade, from awareness and prevention, testing and diagnosis, linkage to care, treatment, and follow-up. And if you want to have a true elimination program, then you inevitably need to have a national action plan, and possibly you have to have at least some political coordinates that are unified throughout the whole of the country. And so that will possibly involve a lot of negotiations with the premiers of the provinces, but I really don't see any other way to do it unless you just leave every province on their own, and what you'll see is some provinces eliminating and others not, but then you don't have borders between them and you're not solving the problem at the end of the day. I think hepatitis C is exceptional because we have a cure. And in that sense, we should be focusing on elimination. And so we should be using the right arguments to get everyone at the table to make sure that we create a common program. I'd like to take that question also to address another issue. I heard someone ask Comey in a previous session, does it take, one political leader who is a hepatologist or a patient to move this forward? The only reason why I was able to push many issues forward in HIV or Hep C was because when I was elected at the beginning, I was a junior MP. Nobody knew me, basically. And when I stepped in one of the first health committee meetings, the patient organizations, who many of them I had treated within the hospital, asked for a hearing. And at that hearing, and I wasn't prepared for that, they said, listen, we've been fighting for our causes for too long. We want Ricardo to chair the HIV and Infectious Diseases Committee within the Parliament. This to say that, of course, it's important to get champions in different places within the political system, but the community And when I mean community, all different stakeholders within the health system can actually help push forward and get those champions moving forward and have an active voice. And we all need to work together. And if in Portugal, despite the financial crisis we were going through, we were able to push the agenda forward, it was also because we were creating these kind of bridges and partnerships between community and politicians, getting everyone on the same page. And I think that is extremely important. And I'll be in Ottawa on Monday, meeting with some officials from Canada, hopefully pushing the agenda forward also.
Mel?
Thanks for that outstanding talk. Towards the end, you spoke about your pushing an agenda where you're trying to have many leaders focus in on hepatitis and HIV and tuberculosis. And Canada has also tried to adopt an STI BBI framework. And one of the challenges we face is that a lot of the population vulnerability is shared between hepatitis and HIV and those things. And in order to, as you highlight, in order to successfully eliminate hepatitis C, you can't ignore that vulnerability and you can't ignore the prevention components. And in Canada, you're aware that we're 10 provinces, 3 territories. How would you suggest we try to align the need for a clear articulation around what's needed for Hep C, and how does that fit into this STI BBI strategy that is being promoted by the federal government and many of the provinces, actually?
Well, I'll try to give the short answer. I think that, first of all, as you were mentioning, Canada is an example in many things that it's doing, especially on HIV/AIDS. And the thing is that if you don't have hepatitis C high on your agenda, you're missing a lot of opportunities where you have all of these different services and interventions within the community that could be used also for early diagnosis and linkage to care of HCV patients. So I would say that it would be extremely important to get HCV high on that agenda. How to do that? Well, I've tried to say it in my presentation in a way, but I guess the most important focus is that we are talking about a deadly disease that can cause cancer, that can cause severe liver disease, and that we have a cure. And this is something that we have to repeat to the exhaustion of our voices, because most politicians are not aware still that this is the reality. On the other hand, there is competition within the pharma market. And that is extremely important because the pricing issue was also one of the reasons why governments were resisting. Now there is room for serious negotiation. If governments want to be serious about this, and we've seen many examples around the world where governments have been able to negotiate because they want to achieve elimination, and so they're trying to focus on these major deals, focusing on treating everyone they can find. So I would say that it's at this point, we have all the technology and knowledge that we need to achieve elimination. We are at the point where we need political will, and we need political determination and leadership. And that's why we created the network, to try to get that kind of leadership. And I truly believe that getting that leadership on board means getting everyone in this room, no matter what their role is, having an active voice. We are not in a time where physicians can just play the role of prescribers. We need physicians, we need healthcare workers, we need everyone to be advocates if we want to achieve elimination within our generation.
Hi, thank you for your talk. You know, it's always a good talk when you look around and all you see are a sea of iPhones taking pictures of your slides. I love what you guys have talked about in terms of value-based procurement and healthcare delivery. And when I sit with some of the government people that I've talked to, at least at a provincial level, a lot of times they're like, wow, this is really great. Now, this is a curative disease. We see that there's money to put into this, then we can make this a part of public health, and it's all wonderful. These are all great things. But can you show us how this might appeal to another disease state? For example, in the context of chronic diseases, because that's a big issue for us. Have you guys been able to take this model at all and start to move it to other sections of your healthcare system, and in particular chronic health issues or chronic diseases, where we might be able to take that back to our policy people who care about that in terms of COPD and chronic disease and cardiovascular disease?
Well, the volume-based procurement approach, right? Yeah. So our primary healthcare system in Portugal, back in 2005, went through a very serious reform, where doctors and nurses and administrative staff that would want to come together and create what we call family health units were free to do so. These family health units basically work almost as if they were a private clinic. They sign a contract with the state based on health indicators, and they have financial incentives if they hit those indicators. Currently in Portugal, half of our primary healthcare system is delivered by these family health units. The other half is delivered by classical health units, where basically doctors are paid a salary no matter what they do. Okay? When you look at the data, and the two main examples that I use are diabetes and hypertension. The number of controlled patients with diabetes and hypertension in the family health units is around 70 to 80%. When you look at the other clinics where doctors get a salary no matter what they do, it's down at around 30%. So I think that's a very good example where value-based procurement truly, or value-based contracting truly works. And it can work in anything. The greatest difficulty, or the greatest difficulties, are, first of all, collecting data properly, processing that data, possibly using artificial intelligence to use predictive models so that you can establish good contracts and deliver the financial models, and choosing the right indicators that are standardized so that you can compare among the different units. So there are multiple challenges still out there, but we already have enough pilots to show that we need to go full stream.
Yes.
Alex?
Again, one of the best talks I've heard, so kudos. So I grew up here in the East End of Toronto. I'll be a few minutes away from the zoo, and now I work in Saskatchewan. And I just have to ask, and I'm not sure that there's even an answer, but what I have found has been the primary barrier with policymakers is not necessarily data or lack of data, but rather the irrational concerns that you described around alienating your voter base and your constituency, political leanings, and then concerns around essentially occult and overt racism and other very complicated social issues. So one thing that you didn't mention is that Portugal has probably the most progressive harm reduction approach in the world. And that preceded, I think, all of this in regards to hepatitis C and so on and so forth. So I guess the question that I have is that obviously in any country there's going to be a wide political spectrum, and certain countries will have more social leaning and other countries will have perhaps a more conservative leaning. But if you're in a jurisdiction where things tend to lean far more conservatively, either from a social perspective or from a fiscal perspective or both, how do you mitigate those irrational concerns with data, with arguments, with other compelling pieces? Because having those discussions, like very frank discussions with policymakers, is really, really hard. And doing it in a public forum is essentially impossible, at least if you want to actually maintain an audience. So that, for us, at least in my mind, has been the greatest challenge, and not only for hepatitis C, but for HIV and all of the other challenges that our province faces, at least.
Well, thank you on the mentioning of harm reduction in Portugal, and the decriminalization of drug consumption was extremely important back in 2000. I didn't talk about that, and I'll leave that teaser because I'm going to talk about it tomorrow, so I won't get into details. So I make sure that the room is full tomorrow. But I would say that when I was deputy mayor of Cascais, which is that small city near Lisbon, one of the programs that I developed was called Smart Health. And Smart Health was a very simple program where we looked at all of the data, health data that was available out there, health, educational, and social data, and that we could get down to the zip code level. And what we did was we translated all the data that we could to that zip code level. And what happened was, at almost the neighborhood level, in Portugal, for example, we have electronic prescription. So we know exactly how many pills are sold in each zip code. we saw in which zip codes how many pills of antidepressant and anxiety pills were sold. And then when we saw the map, we saw that there were some neighborhoods where the numbers were really skyrocketing. So you could speak then with the local leader of that parish, the local political representative of that area, and speaking with them, if they were not aware of this mental health issue, they now became aware. And that information was fully public. It was fully disclosed. And not only now that they were aware, their constituents were saying, even if they didn't know about it, we have a problem in our community and it's your responsibility to solve it. And actually, I saw a poster outside from someone from Vancouver who did something very similar in terms of progression of a Hep C in Vancouver. And I think these kind of geospatial or georeference approaches to data are possibly one of the most effective way to get politicians on board, making sure that they understand that they're serving the constituents and to get the constituents to put pressure on their political leaders. I hope I answered.
Thank you.
Final question to you.
Thank you very much. Well, I first of all want to congratulate you on a wonderful talk. Particularly have enjoyed your combination of vision and practicality at the same time. I want to push you away from economics and the practicality, though, with my question. I've had the privilege of being taught by Susan Sherwin, who is an eminent feminist philosopher, bioethicist, doing pioneering work in Canada. And as her career has gone on, she has moved from clinical bioethics and those early problems to trying to project the theory of bioethics onto the world stage. And she calls it public ethics or public health ethics. The point being that I'm wondering, in your vision of being a minister of health, of being a department of health rather than a department of disease, what role would you see for bioethicists, philosophers of medicine, social philosophers, political science philosophers? Because these people in general are more attuned to the man in the street, as it were, and also have more of a vision of health rather than a vision of disease. It seems like something that would be a very important part of your general operating program, but I noticed you didn't mention it.
Well, thank you. And I understand the remark, but in a way I try to address it in the sense that what I was saying when I showed that what determines our health status, I acknowledge that only 10% of our health status depends on the clinical factors, 30% of the genomic factors, 60% of our health status depends on our social condition, of our social context, of our behavioral context. Acknowledging that is the first step to get politicians on board to a health in all policies approach. Health in all policies means that we have to look at social determinants and other determinants to understand that community health will only improve if we have that broader vision. If we understand that working just with patients within a hospital setting will not solve the problem. And so my vision in the future, and this is what I've been advocating for in Portugal, is that we don't have to have hospital managers or primary healthcare managers. What we need most of all is community health managers, in the sense that they're responsible for everything that happens within that community, which of course includes hospitals and primary health clinics, but they have to be working at the same time with City Hall to make sure that the bike lanes are working, especially where we have most obese populations, that we work with the educational system, and that we have to work with all of those different professions that you were mentioning, the ethicists, the philosophers, because this value-based approach, or this community value-based approach, is most of all a paradigm shift in terms of our culture as professionals working in the health field. As a medical doctor, I was trained to work within a disease system, to focus on disease, not to focus on mitigation of suffering, not to focus on getting people necessarily healthier. And so I would feel that in that future, I would love to see health systems, or whoever's running your public health system here in Canada, also to include those different kinds of professions so that we could have that broader view and we could develop policies, not just present reports, but actually practical policies that could actually transform the system within, which starts with our educational system, making sure that people are prepared for that philosophical transformation, but then that we can implement it throughout the whole of the system. And everyone working within the community understands that no matter what they do in that community, they have a role when it comes to our collective health. Everyone, from the water and sanitation to housing, to the educational system, to City Hall, everyone can play a role to get us healthier. So it's at the end of the day, we need to make sure that the Prime Minister or Premier, whoever it is running the show, is on board to push everyone along. Thank you.
Well, Ricardo, you delivered on the promise. We couldn't really fantastic, wonderful comments, and thank you for the very inspiring lecture. And I really hope that tomorrow we'll continue to learn from you, and then on Monday I hope that you will teach our parliamentarians to follow in your lead and drive the Hep C elimination agenda here in Canada. And with that, so this was the opening session for the rest of the weekend, and we encourage you all to come back for two more. The schedule looks fantastic for the next 2 days, focused on the CASL and the CON agenda, and we'll now welcome you to the opening reception, which will be just outside for some light refreshments. Thanks so much.